So now we are going to go into the different types of wounds, and we'll go starting first with acute and surgical wounds. So if we're looking at an acute wound is an injury to the skin or underlying tissues that occur suddenly rather than over time, like our chronic wounds. These acute wounds should heal in a predicted and expected rate, can happen anywhere in the body, and the causes of acute wounds can be quite broad. Acute wounds follows trauma. Usually this is accidental trauma, and many of these types of wounds, for example after a road traffic accident, will be filled with things like gravel, glass, metal, etc. And one of the first things that we need to do is obviously clear that out. An acute wound can be accidental or planned. So planned, a surgical wound is a planned wound, but things like abrasions, bites, etc. are not planned. The traumatic wounds happen when, for example, you have a sharp object that does a penetrating trauma, which can go down to the tissues underneath, even down to the organs, or else you have cut wounds like sharp objects that affect only the top layer of the skin. One of the things that we start looking at is how are we going to close the wound, and the first thing that we talk about is the three different types of healing intentions. The first one is primary intention, that we'll go and look into a little bit more detail in a few minutes when we talk about surgical wounds. However, then we need to start differentiating between incision and excision. So incision is a clear cut which we can approximate by primary healing, as we'll see later on. When we're talking about excision, we are left with a bigger wound, and therefore we need to heal that wound by secondary intention. So secondary intention is a longer time of healing because the wound needs to fill in with granulating tissue and epithelialization. In some instances, we talked about delayed primary healing or tertiary intention, where we have a wound, for example, a surgical wound which has become infected. We open it again, clear out the infection, and then resuture it back up. That is why we call it delayed primary healing. In order to look at the different type of closures, and you have this example in your textbooks as well, is the reconstructive letter, or some people refer to it as the reconstructive elevator, where it helps us as clinicians to take a decision on what type of technique we are going to use. So as we said before, direct closure or primary intention healing is where we have the edges that can be approximated together without stretching or creating tension on the skin to allow the circulation to function. This can be done in different ways. We can use sutures, we can use clips, there are glues nowadays, or even types of strips that approximate the edges. Depends on the location, depends on how extensive the incision is. It's a specialized type of education that we need to go into, usually in the first years, where people are learning their surgical knowledge. Is that there are also, if you're thinking about sutures, there's a lot of different sutures, a lot of different needles, a lot of techniques. If we're talking about techniques, for example, you have the pearl string, you have the subcuticular. We don't need to go into that, but it's very important to understand that different techniques are used because of the different locations and the different types of wounds that we have. We need obviously to make sure that the wound is clean before suturing it up to make sure that we don't get infection. Obviously always making sure that there is no break in the aseptic technique of closure of the wounds. Secondary intention closure, as we said, is something that is taking a long time, and we cannot close the wounds because the edges cannot be approximated. This is a type of wound that will need us to use different techniques that enhance the healing and granulation of the wound. Again, depends where the wound is, depends on the type of wound we have and the status of the wound. Usually this is where we refer back to the wound bed preparation, making sure that we are allowing that wound to heal through all the stages. Another type of wound closure is skin grafting, which is very popular, especially when it comes to patients who suffer from burns. So skin grafting is taking a section of the epidermis and the dermis, which are completely separated from one part of the body and their blood supply, so you get the skin from what is called the donor side and put it in another area of the body which is called the recipient side. We can talk about split thickness skin grafts, which are composed of the epidermis and the superficial part of the dermis, or else we can talk about full thickness grafts that contain also the full epidermis and dermis. In some cases we do what is called a mesh graft, so they do small incisions in the graft itself, usually through a machine called a mesher. When they do that, then now that skin can be stretched, it covers a bigger area and also allows any effluent from the wound to free drain out. There are other types of situations where we go, for example, for tissue engineering that combines the principles and materials of cell transplantation. It's artificial skin and cartridges, which are some examples of tissue engineering. Tissue expansion is another methodology of doing healing in these type of wounds, where we have a surgical procedure that grows extra skin through controlled mechanical overstretching. Again, you will find more details in your textbook if you want to have more definitions there. One other type of procedures which is quite common is local flaps. So what is the difference between a flap and a graft? The main difference is that a graft, because you take it from a donor site and put it on a recipient site, it doesn't have its own blood supply. With a flap, that part of the tissue is not separated totally and therefore still maintains its own blood supply. When do we use one? When do you use the other? Depends on the surgeon, depends on the wound, depends on the anatomical location. There are other ways and methods that we can use, for example, free tissue transfer and tissue transplantation. If we look for examples of also in burns nowadays, we have graft banks which contain cadaveric grafts and other type of biological type of grafts. If we are talking about a surgical procedure, obviously we are talking about either a planned or an emergency type of procedure. Depends on which anatomical location it is and what tissues are involved. However, what is really important to us is thinking about one of the big issues, which is surgical site infection. So the first thing that you need to look at when you are looking at your textbooks is go to the WHO classification of surgical wounds, where they have explained to us, and this is included in the text, the clean, contaminated, and dirty wounds. And the approach to this is obviously very different. So in order to prevent surgical site infections, there are a lot of international best practice guidelines out there which we can implement, and this includes both the pre, peri, and post-op management of the surgical intervention that we have. If we are talking about surgical site infection, it's unfortunately quite predominant. The statistics are quite huge when it comes to surgical site infection, and again we have a definition from CDC about the different levels of surgical site infection. So we talk about a superficial incisional site infection, which only involves the subcutaneous tissue. The deep incisional will include also the soft tissue of the incision, and then we have the organ and space surgical site infection. What is important also is to us as clinicians on how to manage a surgical wound. There are a lot of misconceptions about management of a surgical wound. One of the unfortunate things which is quite common is that many times we have a patient who has gone to the operating theater within a few hours, even just less than a day, we uncover the wound to respect the wound. If we look at the best practice guidelines, it is suggested that the wound should be left intact for at least 48 hours. The wound is still healing. If we open the dressing, we are giving the risk of the microorganisms going to that surgical site. So the suggestion is to leave the wound undisturbed for 48 hours. If we are opening the wound, make sure that we are using an aseptic technique in order to make sure that we do not cross-contaminate and bring microorganism to that scar. Don't rub the surfaces, you don't need to scratch on the wound, because then you are traumatizing the scar as well. So what is very important is also to look at the different definitions of complications that can happen. So what I suggest to you is to look at the list you have in your textbook to relate to the different types of complications. We can talk, for example, about one quite common complication, which is a seroma, where nowadays we also have a lot of debate about this, because the new classification system suggests that seroma should not always be looked at as a complication, and we only look at it as a complication if it is quite advanced. So the idea here is that we need to understand that acute wounds, being it traumatic wounds, being it surgical wounds, are very different from chronic wounds, and we need to manage them separately. We need to stop talking that we have to convert a chronic wound into an acute wound, because as we'll see, we are talking about chronicity and venous leg ulcers, ischemic ulcers, pressure injuries. The etiology of the wound is totally different, and the objectives are quite different. So we treat the wound according to the etiology, and also in the next section we will be talking more extensively about another common type of an acute wound, which is a splinter.